How do you differentiate different infections? I'll show you. Let's dive in. So you're presented with a patient showing flu-like symptoms. You know, fevers, myalgias, and malaise. It sounds viral, right? Well, what if they also have a headache, an altered mental status, or a neurologic deficit, or a seizure, or meningeal signs? That's right, think meningitis. The etiology of meningitis can be determined by the CSF from a lumbar puncture. All of the etiologies generally have elevated protein in the CSF. Classically, bacterial etiologies show a low glucose, a high opening pressure, and PMNs on the cell differential, whereas viral etiologies usually show a normal glucose and lymphocytes on the cell differential. Bacterial and fungal etiologies often look similar on the CSF studies. You can tell them apart by looking at the cell differential. Bacterial have a PMN cell differential, whereas fungal causes often have a lymphocytic cell differential. When differing fungal causes from TB meningitis, look at the opening pressure. Fungal causes usually have a very high opening pressure. When thinking about the specific bacterial etiologies that cause meningitis and the medications that treat them, it is important to note that these change based on the age of the patient. This table shows the classic bugs and drugs used to treat meningitis based on age. However, it's important to note that these things change, so it is important to keep up with the most current literature when treating meningitis. A general rule is neonatal meningitis is often caused by the gel organisms, that's group B strep, E. coli, and Listeria. Patients over 50 are also at risk for getting Listeria meningitis. So for both of these groups, it is important to add ampicillin into your antibiotic treatment regimen. What if you're given a patient with flu-like symptoms plus a headache and altered mental status, or a seizure, or neurologic deficit, or meningeal signs, and HIV or AIDS with a CD4 count less than 100, and a CT scan of the head that is normal? That's right, think cryptococcal meningitis. It's classically diagnosed with a high opening pressure on the lumbar puncture. The India Ink test is associated with a 75% sensitivity historically. The cryptococcal rapid antigen test is thought to be one of the best tests that we have. It often allows us to make the diagnosis. Historically, amphotericin was the mainstay of treatment. What if you're given a patient with flu-like symptoms plus a headache and altered mental status, or a seizure, or neurologic deficit, or meningeal signs, and HIV or AIDS with a CD4 count less than 100, plus a CT showing a mass lesion in the brain? Think toxoplasmosis. Toxoplasmosis is one of the most common causes of CNS mass lesions in patients with AIDS. Serologic testing does exist, but it is not helpful in the acute setting. Imaging is key. Classically, the treatment was pyrimethamine and sulfadiazine. Again, you should look up the most current treatment when actually treating somebody with toxoplasmosis. Remember, I'm just reporting, not recommending, so put your flamethrowers away. Every patient, context, and test question is different. The tests and treatments of choice change over time, so please use the most up-to-date current literature. Here is a more detailed disclaimer. Don't forget to like and subscribe for more Bucketology content.